So there are a number of interesting trials. We've talked already about the 3-month versus 6-month. That's going to be a complicated presentation to sort out, and we'll be working with that information going forward. I think one very important study is the negative SURFLOCK study, which had been previously presented as positive in terms of liver progression-free survival. And it was put forward that that was going to lead to an overall survival advantage. What's important to understand is that study is now shown to be flat dead negative. There was no overall survival advantage to adding yttrium-90 microspheres to FOLFOX chemotherapy in liver-dominant patients in the frontline setting. There's been some discussion that a post hoc analysis showed some benefit to tumors from the right side. I think it's important to understand when you have a negative clinical trial, any subset analyses are at best hypothesis generating. When you have a unpre-planned retrospective subset analysis of a negative study, that's how a statistician curses someone out. I mean, that's just not actionable data. So if somebody wants to use that information to say, I'd like to go back and do another clinical trial focusing prospectively on people only on the right side, that's fine. But I would think it's a huge mistake to misinterpret that study as justifying upfront use of liver-directed yttrium-90 microspheres in tumors from the right side of the colon. Another interesting clinical trial is the Sunshine study, a randomized phase 2 that suggested a modest benefit for vitamin D supplementation. This is a really nice study that was hard to accomplish. I really congratulate the people who did it. They have correctly said this warrants investigation in a phase 3 study. That's the right answer. I don't believe it's actionable information now. I do not plan on the basis of it to recommend high-dose vitamin D supplementation to my patients, and I don't think that that would be the right answer. I hope that a properly powered clinical trial could find out for us whether it's a good idea or not, and I would caution that there are a number of situations in medicine and in oncology where we found to our surprise on a properly powered study that vitamin D wasn't harmless. So let's not jump the gun on that, but interesting finding. There was also a very interesting presentation asking about using vemurafenib, the BRAF V600E inhibitor, in patients with V600E mutated, BRAF mutated colon cancer. We already showed a number of years ago that as a single agent, that drug was virtually ineffective in colon cancer, despite its having substantial activity in the same mutation when that mutation is in a melanoma or a non-small cell lung cancer. Now, this study is testing the hypothesis that putting that drug in combination with an EGFR inhibitor would be beneficial, and there's good laboratory rationale for that. So the study did show a very substantial, a very significant progression-free survival advantage of 2.3 months. Whether that's substantial from a clinical perspective, we have to talk about. And I think it's important to bear in mind that using vemurafenib, probably going to be in the range of $12,000 a month, plus or minus. Cetuximab, going to be a similar cost. The control arm had a progression-free survival of less than 2 months, suggesting that there was virtually zero activity, and supporting current NCCN statements that the evidence suggests that EGFR inhibitors are inactive in patients with V600E BRAF mutations. So now we're talking about taking over $20,000 worth of drug per month with substantial toxicity for a potential improvement in progression-free survival of 2.3 months. The study was not powered to look at overall survival. It was too small and it allowed a crossover, so it's not fair to say we know anything about that, but I think it's reasonable to conjecture that the benefits would be modest. So this is going to lead to some complex discussions. As of now, vemurafenib is neither approved nor compendium listed for use in colorectal cancer patients with this mutation. Whether these data would change that or not, I don't know. These data have been out there in previous iteration from ASCO GI in January, and so far that has not led to any kind of regulatory or guideline change. I think we'll have to see where that goes. It's important for clinicians and patients to understand that vemurafenib right now would not be covered by CMS and would likely not be covered by insurance companies, although in some situations direct appeals to companies have led to coverage for it. So we're going to have to be thinking about both the physical toxicities and the financial toxicities as we decide whether we can get these treatments to our patients and whether they are in fact important enough step forward that we need to provide that to everybody.